respected chairpersons, good evening to you all. So I will be speaking on the new treatment landscape management of chronic hepatitis B. Before speaking, I'll have a little about regarding hepatitis B. Hepatitis B is caused by the infection with hepatitis B virus. Is the prototype member of the hepatona family. Is the only human representative in this family, has a circular DNA genome 3.2 kb. Currently, 10 genotypes A to Z are identified. This viral genome is a very compact, extremely compact thing. It is a partially double-stranded virus having 4 open-reading frame with encoding with 7 viral protein. So I'm not discussing it details. So you all know there are HBeAg, HBcAg, DNA polymerase, HBsAg, pre-S, 1S2, and HBsAg. So hepatitis is the inflammation of the liver. It starts from the asymptomatic to the hepatocellular carcinoma. You all know. So in this forum, I am not going to discuss about this. Geographical distribution of chronic hepatitis B, according to the prevalence, India falls into intermediate category. HBsAg positive cases prevail 2.4 to 4.7%. So the modern advent of the molecular biological technique, we can identify 10 genotypes classified based on the 8 sequence, complete nucleotide sequences. It differs geographically, different places associated with different frequencies and patterns of HBV mutations contribute to variation in epidemiology, natural history, clinical outcome, and treatment response in different parts of the world. So expression is different. It recognizes immune epitopes differently. Rate of viral replication is different. Pathogenesis and sensitivity to antiviral therapy is different. This is the worldwide distribution of the genotype. India, the most prevalent one is the genotype D. Our interest, especially my interest, was in a northeastern region. We have very limited data. Along with hepatitis D, we have cases of genotype D, we have cases of genotype C in Northeast. This is my own study. We studied in the Northeast states. Seroprevalence was HBV family context. Family context was 14%. Chronic hepatitis B 7.88%. And family context relation was very high, 54.43%. And mostly the family context were the females, especially wives. So large epidemiological study needed to assess the seroprevalence and genotypes in Northeast India. Predominantly tribal population. So tribal population is having more hepatitis B infection. It is around 11%. So why is the genetics is important? Genotype, it has a significance. Genotype A and B thought to respond better to interferon therapy. Genotype A has highest LAM resistance, Geno D ADFOB resistance, Geno C associated with HCC. Precore mutation seen in the Geno B, C, D associated with E-negative chronic hepatitis B. Basal core promoter double mutation is seen in Geno A, C, F associated with HCC. Geno D is lowest chance of having seroconversion with interferon. So now I'm coming to the management outline. So goal of the therapy is one, and when and what to start, guidelines, new treatment options, if any, then choose among good options. So cure as a goal of the therapy. There are two things. One is actual cure, another is functional cure. True cure, that means no virus is there, all virus is gone. Very difficult because of the CCC DNA. Functional cure, there we use some markers. HBsAg loss, ideally anti-HBsAg should be there. Possibly sustain off-treatment inactive disease without HBsAg loss, that is HB is negative, EAG negative, HBV DNA undetectable, normal ALT, normal histology. So this should be the goal, actual cure and functional cure. And cure not so simple, reason lie with the virology. So I will not discuss in details. You know that virus attached to the hepatocytes, entered to the hepatocyte with a relaxed circular DNA. It enters the nucleus and transform into CCC DNA. CCC DNA is a complex chromatinous materials wrapped by a histone, and ultimately that CCC DNA used as a template, and templating transcript they become ultimately is a viral protein, and there are different viral protein. They encode with DNA polymerase and also other proteins, and ultimately the encapsulation takes place with the pregenomic RNA. Pregenomic RNA ultimately the reverse transcribe all the protein, and it forms an envelope. That envelope released to the circulation, and some part is recycled and goes to the nucleus and form the reservoir of the hepatitis B virus. So CCC DNA is the main problem in this virus to cure. The potent HBV DNA suppression with nucleotides. We have nucleotides, you all know, that entecavir and tenofovir. The study shows that long-term therapy with the potent nucleoside leads to suppression of almost all, both in hepatitis E positive and E negative cases. HBV therapy reduces risk of disease progression. If you see that treated, the responders are doing very well, that antiviral therapy improve transplant-free survival. So those are untreated and non-responder is not doing well, the treated are doing well. So need for long-term therapy? Yes, we need for long-term. If you cut this therapy early, in the 6 months, say in the both sides, that this slide shows that if you cut early in the 6 months, so there is replication is more, remission is more. If you continue for 36 months, so there is a good response. So long-term therapy is required. Long-term oral HBV is highly effective, suppress HBV DNA, normalize ALT, prevent fibrosis progression, promotes fibrosis regression, even cirrhosis, prevent and even reverse hepatic decompensation, reduces but does not eliminate the risk of HCC. Long-term therapy is effective, but low rates of HBsAg loss. Long-term therapy, the downside, there are toxicities, there are renal toxicities and bone toxicities. High with lamivudine, not preferred guideline. There is no guideline in EGEL, that American and Universal, they are not preferred this lamivudine nowadays. Very low with the entecavir and none with the tenofovir. Cost and adherence is a matter. When and what to start? American Association of Study of Liver Disease and EGEL, European Association of Study of Liver Disease, they are giving guidelines. If both E positive and E negative cases, if the case is viral DNA is more than 20,000, upper limit ALT 2 times upper limit equal or 2 times upper limit normal, no liver disease, this is not applicable. And E negative cases, it is equal or more than 2,000, and ALT is double the upper limit, and liver disease is not there, so we can treat with nucleoside analog. And in case of cirrhosis, we need not see any this viral DNA or ALT or anything. So EGL is also recommending same thing, that EGL is saying that it is 2,000 instead of 20,000, but it should be upper limit, greater than upper limit. Usually we take the 40 unit is upper limit, but American, they are showing that they are taking it as a normal ALT level is 31 for male and 19 for female. For the all practical purpose, they are taking 35 for male and 25 for female. So why EGL is saying 20,000? Because it is maybe that 20,000 viral load is the most inactive carrier level. So beyond that, they are trying to treat it, unlike this ASLD. What to start initial HBV therapy? There are anti-KB, tenofovir, dipiboxil, and pegylated, very good drugs. They are the first line of drugs. The EGL and the American saying yes. For pegylated interferon, of course, that we should only consider as an initial therapy for patients with mild to moderate chronic hepatitis B, selected patients, compensated cirrhosis, no portal hypertension. They are highly potent, all drugs are highly potent. Adafovir, lamivudine, and telbuvudine, no, because of genetic barriers, low genetic barriers. Whether these analogs are safe for HBV, generally very good for long-term safety, but individual patients may have different toxicity. Current option in 2019, we have tenofovir dipiboxil and tenofovir alafenamide. So now I think in 18 and 19 we should all have this tenofovir alafenamide. Why I'm coming now? So in GI tract, it absorbs tenofovir dipiboxil, mostly it goes to the renal, plasma concentration is more and goes to the renal tubular cell, renal damage is more. And the tough tenofovir alafenamide, the 90% lower plasma concentration than the tenofovir directly. So it has a direct effect on the virus. So tough, no dose adjustment is needed. Patient with creatinine clearance greater than 15 ml per minute. Tough versus TDF, chronic hepatitis infection with 96 efficacy. They are very good drugs. You see in the ALT normalization, 96, tough and TDF is both good, and higher rate of HBeAg seroconversion at 96 weeks versus 48 weeks, TDF and tough, both good. And in negative cases also, minimal decline of HBsAg is seen, but only one case is genotype A had HBs loss and seroconversion. TDF in chronic hepatitis infection, renal and bone density outcomes. They are very minimal effect. There is similar effect seen in both positive and negative cases. So almost all, if there is no comorbidity, we can use monotherapy, anti-KB, tenofovir, and tough. Only that those conditions, comorbidity condition and bone disease, renal abnormalities, we have to choose the drug, tough and anti-KB. So these are the options for managed patient with nucleoside resistant cases. See the left side, resistance are adafovir. If you have adafovir resistance, now it is not used, the give anti-KB shift or add anti-KB, the same thing. And if there is patient is anti-KB, go for tenofovir. Lamivudine nowadays we don't use, go for tenofovir because of the high genetic barrier for the middle group of drugs. And multi-drugs, you can add both drugs, but there is no added benefits. Creatine clearance, you have to reduce anti-KB doses if it is less than 50 ml. And the same thing with dipiboxil also. And tough, you need not do the dose reduction if clearance is more than 15 ml per minute. Dose not recommended for 10 ml without dialysis. Should patient receiving TAF switch to the TDF switch to the TAF, tenofovir to TAF, alamfetamide? So there is also, this analysis shows 88% patients achieve virologic suppression at 96 weeks and maintain up to 24 weeks. So significantly higher proportion of the patient achieve ALT normalization after switch to TAF. So conclusion, the patient without comorbid, 3 highly effective preferred options with higher barrier resistance, entecavir, tenofovir, and TAF. Entecavir and TAF useful for patients at high risk with current renal impairment or bone toxicity. In such patients, consider entecavir if creatine clearance is less than 15 ml per minute, and TAF if the previous nucleoside exposure is there. Guidelines suggest useful to switch to TAF for patients with current toxicity. Equally effective viral suppression with TAF as TDF for faster ALT improvement. Nucleoside analog therapy is highly effective but not curative. HBV DNA suppressed but low HBs AG loss. Long-term therapy required. For most patients, entecavir, TAF, and TDF similar. TAF has a similar efficacy with improved renal and bone safety compared to TDF. With this, I conclude. Thank you.
What about in pregnancy, drugs in pregnancy?
Which one is?
In pregnancy.
In pregnancy, usually the third trimester we should give the drugs. Then drugs like TAF, there is limited data, but you can use entecavir and the tenofovir. The rest of the drugs are LAM resistant, and then interferon, pegylated interferon, you should not use. It is contraindicated. Which one? TAF is available, yes, very much available for 18, since 1918. The TAF is and it is the day for the TAF. You should use TAF. It has a very less toxicity and very effective.
Sir, why treatment guideline is different for EAG positive and EAG negative patients?
I mention it because that only differed only 2000 and 2001. Rest is almost same because they thought that 2000 viral load is usually in negative cases viral loads are very low, and 2000 if it is that total viral load is 2000, it is seen that they are inactive carrier state. That is why they up to 2000, beyond 2000, so there may be active disease. That is why they give they do not wait till 20,000. The European, they use it at 2000 only, if crossed beyond 2000. Yeah.
Thank you very much for your excellent presentation. We close the session now.
Thank you.
Now I request the speaker to please come on the dais and take the memento from the chairman. Please come, Rajesh. तस्वीर दे दो पहले. क्या राजेश जी आपका तस्वीर है?
Thank you very much.
This is mine.
No, chairman.
Thank you.
दे दीजिए इनको. सबमिट कर दीजिए. दे दीजिए.
नई फोटो रखिएगा.
So thanks everybody for cooperating with us in the late evening. Please wait. and our dinner will start from 8. Huh? Everybody is cordially invited in the dinner. Please wait.
Sir, if you action it to the